Good afternoon, everybody. Now, this is the time that in the future we'll probably be networking, because that's one of the values of coming to these things. And don't be afraid if you're a student to say, hi, I'm so-and-so from so-and-so. It doesn't hurt. Hey, Margarita, I recognize her from Spain. Who else is out there? Who else wants to be brave and say hello?
Hi, doctor.
Hey, Margarita, how you doing?
Hi.
Margarita works with Dr. Llanos, a Spanish neurosurgeon. He's a neurovascular surgeon, right, Margarita? Is he
Yes,
considered?
it is. Yes, doctor, it is. I have no camera. Where is my camera?
Oh, no camera? Your camera doesn't work?
No, don't work.
Oh, I don't know. Yeah,
I think that you have not connected me like panelists, and I cannot come.
Oh, I see what you mean. I see what you mean. Yeah. Yeah, you're probably right. Yeah. Yeah, we'll see. You're coming in now. There you go. Okay. Magic. Now you're muted.
Yes, we are here. Hello to everybody, and I think that we are going to have a good lesson.
Yes, he always gives good lessons.
Yes.
And it's an advantage for students today to have access to people like SAMER. Does anybody else want to say hello and meet Margarita and me? It's not being, oh, it is being recorded. It's on YouTube. Sorry about that. We usually edit it after. So, sí, la charla de Cuba, muy interactivo, huh?
Very good. Muy buena.
Sí, sabes que, Margarita, yo creo que el tamaño de 4, 5 neurocirujanos es bastante para discusión. Y yo he visto, wow, es confortable, puede hablar mucho. Si es más grande, más neurocirujanos, no hay tanto interacción a veces.
Sí. Y después Bolivia.
Voy a Bolivia.
Hoy día completo. Today is a very complete day.
Mucho viajando, ¿eh?
Yes.
Viajando a Cuba, Bolivia. Sí, la mayoría de estudiantes está de Irak. SAMER tiene clases en persona allá en Irak. Parece que es bien asistido, well attended. Si la estructura cambia, a veces es poco lectura, poco huevo de CT scan, MRI, discusión o cualquier. La última vez ha tenido una charla con Warlicks, pues Sungurn, una neurocirujana de Thailand, también un artista y pianista, pero ella no le gusta hablando de esto. Porque yo siempre dice que, oh, toca el piano. Dice que no. Oh, Muhammad, ok, está tratando de entrar, ok. Muhammad puede entrar o no puedo. Yo creo que tiene lo mismo problema con, aquí está. Tú, peronista, qué bueno. Venezuela. Alguien de Venezuela. Dilma Natera. Diga hola, Margarita.
Hola.
Que déjame ver si necesita entrar como tú.
Ah, puede ser.
SAMER'S está aquí. Hello, SAMER.
Hello, hi John. How are you?
Good. How you doing?
I'm okay.
Okay. What is the structure going to be tonight? Today,
As
basically.
of- basically, 2.5 hours quiz, 2 presentation, 3 cases through operative videos. That's the
Okay.
plan.
Yeah, I'm sorry to put a time on it, but we got to finish in an hour and a half. 'Cause
Yeah,
we have another.
maybe, I don't know, maybe we can finish in hour and a half.
No,
Well-
yeah, we don't. Hopefully, it won't be longer because I got to start there. There's,
Yeah,
but an hour and a half's enough, I think, for you, right? I
Yeah,
think that's enough.
yeah, we can arrange. Just I need like a reminder before 10 minutes if it's possible.
Yeah, I will. Yeah, and also if you want to do more, you're welcome to do more.
Thank you. We'll have on the next days.
Yeah, let me know. Let me know. You want to have one Tuesday?
No, Tuesday I can't. Maybe Saturday and Sunday, the next
Okay,
Saturday.
just let me know. Just let me know.
Yeah, I need
Because
Saturday.
this is a good time for me.
Yeah.
Because I get all my conferences early from India and from the Middle East and stuff. This is like my afternoon here is free.
Yeah,
So it's a good time.
that's good for me. Yeah, so basically next Saturday and Sunday, same timing.
Yeah, that would be good.
Okay. And would you like promote me to add people?
Oh yeah, let me make you a co-host there. Let's see, there's Jaffer. Who wants to be a co-host? Do you have an assistant? Tiva, are you there? Who wants to be a co-host and help Samer? Tiva, you want to help Samer?
Yes, of course. Can you hear me?
Yeah, I'll just make you co-host, okay?
Okay.
And do you know what the duties are?
Well, I'll mute people if they're unmuted.
Yeah. It's not real complicated.
Okay.
Okay. Hmm.
Hold on, let me get you TLKT. Look. They're muting and also admitting people too. When they come in, do you know how to admit people? Let me show you. Go to the panelists, the name on the panelist, go to the far right. There's 3 dots.
Yes.
Do you see those 3 dots?
Yes.
Okay, click on that and a menu opens. It says promote to panel.
Yes,
So
I
you
can-
want to kind of look at that every now and then and promote people.
Okay.
Are you ready,
Okay,
Simmer?
thank you.
Yeah, I'm ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from beautiful Miami Beach here in the background, the home of Neurosurgical TV. We have the pleasure of broadcasting a series of webinars by SAMER'S, MD, a neurosurgeon from Iraq that is a mentor to many students in Iraq. He's currently in Cincinnati doing a fellowship, and he's going to run the show. Welcome, Samer. It's all yours.
Thank you, John, and thank you for this opportunity, and thank you for the Neurosurgical TV to host this basically student and graduate-based neurosurgical activity. So today is the 7th session of our 9th neurosurgery mentorship, and we have scheduled a few items to cover the first 1.5 hour, which is the permission today. And if we need more time, we will send the link through the group and we will continue offline. So basically, I will start with the quiz first, then we will go through presentation, then we will go through 3 cases, operative video from radiology to operative scenario. So I need volunteers to start the quiz. We have 4 questions. I need 4 volunteers. More names. Yeah, I want to try more and more names. Okay, so definitely I will start with the Muhammad Imara.
Yes, doctor.
So you are number 1. Haider is number 2. Osama is number 3. And Taha is number 4 for the first 4 questions. And yeah, there is a lot more. I will share now, and we will try to give a result for like 5 out of 7, 7 out of 10, whatever the correct answers. And yeah, Taiba will give us the result. And always my first advice to keep your screenshot well arranged, desktop screen well arranged. So the idea is I'm starting with Muhammad Imara, and yeah, Muhammad. So the first, your quiz is about cranial foramina. Are you comfortable with this topic?
Yes, doctor.
Okay, so basically it's a crossword puzzle. It's simplified form to give what's the horizontal, what's the vertical. So you need to have the answer, then you match the correct term with the number of letters inside. Okay, And that goes with what I like more, and you already noticed through discussion to be focused, to answer with one term first, then if wanted, you can explain. So I will read these one by one, and you give me the answer, and I will start from now. So for horizontal, number one, which is this one, middle meningeal artery pass through it. We are asking
Right.
about cranial foramina.
Foramen spinosum.
Number two, called anterior condylar canal, which is this length. Any answer? Number four, it's not obligatory for all. We are just trying. Number four, horizontal. What's the cranial foramina conveys the maxillary nerve?
Remainder tendon.
I'm testing Muhammad Imara now.
Oh, sorry.
So yeah, he must answer all these. Then we go. I reserve a little tough one for you, Osama. So I will consider this answer because yeah, convey the maxillary nerve, and this is rotundum. So this will be added to Muhammad answer. And number five, which is this horizontal, was the cranial foramina that convey 3 cranial nerve within 70% of parasympathetic fiber of the body passing through it, with 70% of parasympathetic fiber of the body passing through it. This is number five.
Foramen magnum.
And number six, the motor fiber of the fifth cranial nerve pass through it. That's not easy. Sorry, I will continue. We have two more vertical answers. So number one is the in the vertical, so the extratemporal segment of the facial nerve pass through it, not this foramen. The extratemporal segment of the facial nerve. Okay, so number three, the vertical is closed inferiorly with the membrane, and the antenna carotid artery exit from it to enter the cavernous sinus. What's the description fit to which cranial foramina? So it's closed inferiorly with the membrane, and the antenna carotid artery exit from it to enter the cavernous sinus. And this is the letters. And that's it. Do you have an answer, Tiba?
You mean the score?
Yeah, sorry.
So yes, he did 2 out of 7.
Okay. This is just to have the trial, because when you see them, it's easy. When you are the involved person, it's more difficult. So who's number two?
Hello, doctor. I'm Haider.
Yeah.
Third year medical student at Iraqi University, Iraq, Baghdad.
Welcome, Haider. You are new to the board. So, yeah, Haider, your topic will be brain herniation syndrome. Are you comfortable with this topic?
Doctor, we don't have a clinic in our study. I'm only 2 years and going to the 3rd year.
So I would suggest your answer will be direct to the question. My question was, are you comfortable with this topic? The answer is no. That's it. You don't need to give all the possible causes. So I will go with you to the next one. Cerebral veins or no?
Yes, doctor.
I know this is for 3rd year board student. This is for 3rd year resident. But let's try. So cerebral veins. For you, you have 1, 2, 3, like 10 questions. And Osama, do you want to help Haider with this? So you can both of you answer together.
Sure, I could help out.
So it will be like more fair if two students try to find this. So for number 1, found in the what's the cerebral vein found in the superior part of the cerebellopontine space, also known as vein of Dandy. 1, 2, 3. Okay.
Should I
Number-
answer? Or
Yeah,
should I leave it?
both of you, like it's a one run for both of you just to help each other.
So my answer for the first one is superior petrosal vein.
Number 3 runs in the Sylvian fissure and drain into the basal vein of Rosenthal. This is the letters.
Mhm.
The idea that you should have the answer first, then you should choose the term of the answer or the description that should fit to the letter. Do you have answers, Haider and Osama?
No, doctor.
Okay.
I think number 3 is going to be could be superficial middle cerebral vein.
Number 4, I don't know. The result is with Tiba. So number 4, run in the velum interpositum inferiorly. So what's the venous structure that run in the velum interpositum inferiorly? It's tough. I'm sorry. 1, 2, 3. No answer.
No.
Number 5, join the septal vein to form the internal cerebral vein at the foramen of Monro. And it should be fitting here. So 1, 2, 3, no answer. Okay. Lies in the quadrigeminal cistern and unite with the inferior sagittal sinus to form the straight sinus.
Great cerebral vein, vein of Galen.
Which one fit here?
Great cerebral vein.
Okay. I will continue. Anyway, I don't know it's true or false. I don't have the time to count the letters. 7. Connect the superficial middle cerebral vein to the transverse sinus. So it's very short word. What's the venous structure that connects the superficial middle cerebral vein to the transverse sinus? 1, 2, 3. Any answer? Number 8. Yeah, if you have an answer, give it. Like, you don't need to think a lot. Like, this is like sport. I will go to number 8. Anastomosis with the superficial middle cerebral vein and the superior sagittal sinus. So it's the anastomosis between the superficial middle cerebral vein and the superior sagittal sinus for number 8. 7 letters. I feel like this is a TV show.
Well, I think it's like you have to count the letters.
Yeah, like $1 million show. 9 has an intimate relationship with the posterior cerebral artery and ends in the vein of Galen. Number 9. Okay. So the last one is number 2, which is the vertical connecting all of them, which is a vein that can be sacrificed during the supracerebellar infratentorial approach to the pineal region. 1, 2, 3. Any answer? Okay. You don't need to give us the result. Tiba. It's a tough one. Yeah. I will give you some ideas about what we are doing, what's this type of quiz, how we make it an advantage, and also what is the best resource for this. Thank you, and let's go with who was number 3.
That was supposed to be me.
Yeah. Yeah, okay. Number 4. Wait, Samuel, let's see.
Number 4 is Taha, I think.
Yeah, Taha, are you ready to herniation syndromes?
Yeah, sure. Is there any?
What, sorry?
Is this the last one or like, is there any other?
I don't know if you want. This is the last one, the differential diagnosis of intraparenchymal ring enhancing lesion.
No, that's fine. I wanted the veins, but that's all right.
The veins is done. So
Yeah. Okay.
anyone is volunteering with Taha to work together on this?
I
Yeah,
could help
Jeff.
Taha with herniations.
No, let's try Taha and Jafar Hassan. Yeah. So yeah, I will take you through this. This is just simple 5 questions about the brain herniation syndrome. And so the first question is number 2, which is the first horizontal, characterized by compression of the posterior aspect of midbrain with mid-sized pupil, fixed pupil, and hyperventilation. And it should be fitted here. Number 3, which is this horizontal, 5 letters, characterized by, what's the brain herniation syndrome? That is characterized by ipsilateral fixed dilated pupil with or without contralateral hemiplegia.
That's temporal herniation.
That's too much for the space.
Like temporal.
Uncle, that would be.
Sorry.
Uncle.
No.
Number 4. I will take both answer and we will wait the result later. Number 4. Herniation syndrome characterized by a downward displacement of diencephalon. And this is 7 letters. 1, 2,
I
3.
think it would be central.
Sorry?
Is that central herniation?
Number 5, also known as herniation through the foramen of magnum. 9 letters.
Maybe it is tonsillar herniation.
Someone is jumping from the crowd. Yeah, keep it later. But thank you for your help. If it's helpful, do you have any suggestion, Taha or Jafar? Okay, I will. If you have a word, just spell it. Which one?
I don't know the names of the syndromes. Like,
okay, you will know them today in the tough way. So the last question. The last.
Do we have
question,
to answer now or later?
if you have a word, just say it. For number 5.
I think which one I said? Uncle. 3 would be uncle. Is that correct?
I don't know. I want to complete this.
Oh, okay.
Do you have a suggestion for number 5?
Oh, number 5. Yeah, a good suggestion would be tonsillar. Yeah, as someone who answered.
Vertical. Only one word connecting all of them, which is characterized by midline shift and may cause ACA infarction, which is anterior cerebral artery infarction. Daha and Jafar, any idea? A type of cerebral herniation that's characterized by midline shift and may cause anterior cerebral artery infarction. And thank you.
Okay.
Let's. We don't need the score from you, or do you have a score, Tiba, for this?
Yes, I do. Do you want it?
Yeah, just
Oh,
number.
they're cutting scores.
The help of Huda, it's 3 out of 5. So
Okay.
that's pretty good.
So, who's the volunteer for this one? I need one or two. It's open.
I can help
Mariam,
with this one.
Mariam, Naji, and Abdulaziz.
Hello. My name is Mariam
Yeah.
Naji Awadi, MBS CHB from Baghdad University College of Medicine.
Hello, Mariam.
Hello.
And
So the first one, the most common cause of
wait,
multiple.
wait.
Okay.
Okay,
sorry,
and
sorry.
Abdulaziz, are you ready?
Yes, I'm ready, doctor.
Yeah. So both of you, it's just a one run. It's not so both of you are on the same team. So
Okay.
we are trying to answer this differential diagnosis of intraparenchymal ring enhancing lesion. We have the following 6 questions connected and should be matched with the letters. We'll start with horizontal. Number 1, what's the most common cause of multiple ring enhancing lesion?
I think so. That's multiple sclerosis, demyelinating disease. Multiple sclerosis.
What's your answer for this?
Multiple sclerosis.
I think too much for these letters.
Meningioma.
Oh, sorry. Number 2, commonly seen in HIV patient. So what's the ring enhancing that's commonly seen in HIV patient and should be fit in this?
Cryptococcygenes.
Number 3, I will not answer at the end. You will have all the answer. This is just I want to put you both under stress. So number 3,
Okay.
the most common primary brain tumor causing ring enhancing lesions.
Glioblastoma.
Number 4, common in immune competent adult patient. Obviously, this is the opposite of number 2. So number 2, common in HIV. Number 4 is more in immunocompetent. And number 5, usually in immunocompromised. This is the opposite, sorry. Usually in immunocompromised. And all should be ring enhancing lesion, a well-known ring enhancing lesion. And the vertical that's connecting all of them is characterized by an incomplete ring. So what's the pathology that's characterized by having incomplete enhancing ring and should be fit in this? I think maybe Mariam said just the correct answer for that.
Multiple sclerosis.
Okay. Do you have any result, Taiba?
Yes, 2 out of 6.
No, that's good. So,
okay. Thank you.
Thank you all for this. Is like a hot seat.
Thank you, doctor.
You're welcome. Examining someone is always a pleasure. You will enjoy it later at a later stage. So the idea is that like we are proud of this book, and this book is in the market, is already in Google, in Amazon. It's the Neurosurgery board favorite crossword puzzles. This is a very unique book. It's the first of its kind, definitely. And most of my professors or mentors, when I send them this book or I give them this book as a gift to remember, they said, wow, what's this? Are you addict? how you came with this idea? And yeah, this is very interesting just to have a different perspective on you are enjoying the study of neurosurgery. It's not just you are studying neurosurgery. So we make a crossword puzzle, and this book goes with, like, you can see many resident and student. I think 2 out of 10 as in neurosurgeons. And the forward was from Professor Ayub Cherian. He's now in India, and yeah, he described it as a beautiful landscape with mountain and jungles. And also we have the other forward from Federico Nicolosi, who's the upsurgeon founder. And yeah, he described it as a vision and invention. We put this just at the first 2 months of COVID era. So this is the result of COVID. I have this idea. We have 50 crossword puzzles, and exactly it's 524 questions in total. And this is just a new way of learning or testing people's. And we have a dedication for Professor Saad El-Witri, who's the founder of Neurosurgery in Iraq, and to all those warriors in the field practicing neurosurgery. And yeah, the idea is that section 1, which is the basic level neurosurgery, that's the one that you are answering 5 minutes ago. So this is the basic level. The basic level, this means that what are the branches of facial nerve? What are the area without blood-brain barrier? So it's not only enumerating as a list, to have a very characteristic description for each one. That's the challenge. We put 40 of these, I think, yeah. Then the advanced level, I will show you the advanced level later. And the advanced level is subspecialty oriented, like neurotrauma, functional, oncology, vascular, definitely vascular. There is vascular 1 and 2, and even for history of neurosurgery or neurological examination. Then at the end, you will find the answers. So how to use the book? I think you already know now how to use it. And yeah, we put it just to simplify things. So there is questions, and you put it like this. And for the advanced is totally different. If anyone have an interest or already so the crossword puzzles and the journals, this is the typical crossword puzzle. So you need to know the vertical, horizontal, and you need to match it. It's much more difficult, and I bet you it's not an easy job. So and we add something. If you notice the cover letter, it's one of our student, which is Tiba. I think this is another Tiba Muhammad Ghanem. She's this her signature. She's a writer, and she has an artistic background. So we ask her, because this book is just about entertainment within neurosurgery. So she provides us with illustrations and quotes, and we put it like every few questions you will find. Sorry. Yeah, this is not typical. However, yeah, the idea is that you will have a picture which is drawn by Tiba, and then you will have a quote between like every 3 questions. Then you go through questions like this, and this is for volume 1. And yeah, this is like a lot of quotes and drawings, all are original. It's a way to support our medical student with a special talent. And yeah, after the 40 question, we go to the advanced, and the advanced, you will see this one. It's very difficult. I think I tried this on many neurosurgeons and residents, and in the best instances, it take them 2 hours to answer one of these. Many of them, it takes 2 days, and maybe 10%. It's not there is no a full answer yet. So yeah, this is the thing. It's a deep questioning, and how you put it, you will try to answer this. I will give the book as a gift for all the team that we have and the groups, those who are registered. I will send a copy of the book, so you can try this and give us feedback, give us idea for the future. And definitely you may give us a correction for that. And yeah, that's the idea. It's very challenging to put all of these, and at the end we put it as a resource, and we describe it initially in the book description that the best answer to this is those websites, and I would prefer Google for that, because that's the idea, to have this one as a question, then you go to Google, search for the answer, then you try to put it, because it's not difficult, it's not uneasy to put this. If you see that this is radial, okay, but this is not a word, neither from upside down nor from down up, because some words are just distributed letter, and you should choose which letter where. So that's the first part of today, and yeah, I will send a copy of this, and you can find it also in Google and in Amazon. I think many publisher already have this. This is we made it cheap, like $5, because we know that this is just a thing that we want to enjoy with and to share with other people. And for those who are doing the exam today, yeah, you will find the answer for your quizzes, and you have already the title and the numbers. Any comment before we go to the next? Any suggestion? Haidar, Jafar, yeah? Do you have suggestion, Jafar? Or
I want to say that it's fascinating and very amazing to perform and create this book. So amazing job. Thank you for making it. I'm proud that an Iraqi team did make such a fascinating thing.
Definitely we thank you, and I'm proud of people like helping me doing that. And yeah, this is just to share with you how easy to think, how easy to enjoy studying. This is a totally different form. And yeah, what we are really proud of when any professors I show this book to them, they say, wow, this is not an ordinary neurosurgery. This is a real passion in neurosurgery. And yeah, this is sometimes you have such things that like a sample of your passion, and at the same time I'm sharing this here just to remind you that the doors are open for you to cross to the next level. It's up to you. It's just an idea, and we can go through this. Thank you, Jafar. Haidar, do you have a comment, or this is the hand for the quiz? Okay. I want to see if Yunus is here. Is he in the panel?
Yes, doctor, I am here.
Are you ready?
Yes. Shall I start?
Yeah, you can start, and for all the attendee, you need to just to give me a reminder to share the book with you, and also to the link for the publisher, because I may forget. And yeah, any idea for any book, we are open to discuss, and I think we have the enough experience to do that. We already have 4 books published, 4 chapters, and I think we have like 6 ongoing projects. 2 of them are just full books ready to submit. So I think we can help each other, and I think we can help in maturation of some ideas, because like when we publish the first book, I will talk about this book next Saturday, I think, how to write a book at all, and the ideas about the process of writing and the end from zero to the publishing. But yeah, part of this story is that many people has many ideas of book, and actually hundreds, and they don't end with a real book at the end. However, it's easy if you have just figure out what's the real process of the book. So when you write it, you know what's the end product will be. That's very important, like to know what's the process at the moment that you are start the writing and the planning. Otherwise, there is many people contacting me and say, I have a book written, it summarizes all the residency in 300 pages. However, it's written, it's not printed. I need to make it available as a Word file. Then the book has many pictures from all the text, and what we can do with these pictures. Either it's a genuine that we make these pictures, or you should have the permission for each one, for each figure inside the book. So it's an endless process, and it will not end in a real achievement. So that's the talk initially, and we will expand on these more on the next, I think next Saturday. Yeah, are you ready, Yunus?
Yes.
Yeah,
I will
go
start sharing.
introduce yourself, share your screen, and yeah, the screen is yours.
Thank you. Well, hello everyone. My name is Yunus Mazen, and today I will share with you my experience in presenting for the first time in the Hose Neurosurgical Mentorship. And as you can see, the title of my presentation is No Time to Prepare. And actually, I inspired it from the last movie of the James Bond series. And you will see why next in the next few slides. First of all, let me introduce myself. I am Yunus Mazen Joda, a fourth-year medical student at Anaheim University, and I am also a member of the 8th Hose Neurosurgical Mentorship. So, how it started? The 8th of September 2021, we were attending a session at the hospital with Dr. Hose, and after the session ended, we started discussing the cases, and in the middle of this discussion, Dr. Host looked at me and said, you should present a presentation about the spine and today. And actually I was shocked because, as everyone knows, and as Dr. Host told you before, that if you are interested in spine, then this mentorship is not for you. So this was like a shock for me. And also he wanted that presentation at the same day. However, I told him that this was like a challenge for me, and I accepted the challenge. And he started giving me some information and some sketches about the presentation that he wants. And actually, I still have this sketch with me because this was like a special memory for me, and it was a special day because this was my first time. Now, let me give you an idea about the timeline of this process. So at 6 p.m., I arrived at my house and started preparing my presentation. And at 7 p.m., I attended a virtual scientific meeting with Dr. Hose. And at 8:15, the meeting ended. And at 10:30, I started presenting. Just as simple as that. So you can imagine that I had only 3 hours to present my presentation. And now for the outcome of that presentation. Well, everyone was surprised and astonished by the presentation. And that was for 2 reasons. The first one was the short time that was given for the preparing of this presentation. And the second one was the amount of information that was involved and included in this presentation in particular. So these are some screenshots from my presentation, as you can see. And these are the topics that we discussed. We also had a quiz at the end of the presentation, so it was an interactive session, actually. Now, let me take you behind the scenes of preparing my presentation and how I take it that way. The first point that helped me in my presentation, that I prepared it as a concise content. What do I mean by that? I mean by that I prepared my presentation to be short and concise, and it contained a high-yield content and information in just a few slides, so that everyone stay attached to me and not get bored of my presentation. The second one was a neat and eye-catching design of the presentation, because who doesn't love that? It's very nice to have a presentation that is eye-catching. The third one was confidence. So as Dr. has always told us, that you need confidence in your career to be successful. You always need to be confident with your information if you have them from a respectful source. So as long as you have your information from a respectful scientific source, you always need to have confidence and present. And the fourth and last point was the help of my mentor, of course. So Dr. Hoz, as I told you before, he gave me some information. And although it was just a few tips and notes about the topic, they helped me a lot in preparing my presentation. So the challenge was passed for me, and I am really excited about preparing a lot of new presentations. So actually, I contacted Dr. Hoz this time to give a presentation, because this was a very unique experience for me. And also at that time, I was awarded by giving a second presentation at that mentorship, and it was about a more specific topic, which was the MRI of the cervical spine. And thank you for your time. And this was my first presentation and my experience.
Thank you. Go to the next.
Okay.
Because this is very good time, like it's short and concise. I would like to comment on both together. I can say one comment before we start the
Yes,
second one. Yeah, that definitely this is very moment of proudness for me at seeing you presenting with that level. And yeah, everybody knows that definitely I'm not helpful for you in that topic, because you are talking about spine. So you are honest, you are totally honest when you say that he didn't help me in details. Yeah. So I think it's very good effort, and the most important is confidence. And also I like the slides and the presentation. It's always different, and I congratulate you for that. And yeah, let's listen to the second presentation.
Thank you very much, Doctor. The pleasure is mine. Now I will talk with you about the case report that I am working right now with my colleague Fatima, and it's about RAA with ALSA. So you might be wondering, what does that mean? Well, let me explain to you what is RAA. So RAA stands for right-sided aortic arch. Is my screen clear? Okay.
Yeah.
So right-sided aortic arch is what RAA stands for is right-sided aortic arch, which is a rare anatomical anomaly that is found in less than 0.1% of the population. And according to the Edwards classification of this anomaly, it has three types. The type 1, which is right-sided aortic arch with mirror image branching. The type 2, which is right-sided aortic arch with apparent left subclavian artery. And the type 3, and the final one, is the right-sided aortic arch with isolation of the left subclavian artery. Now let's talk about our case. So a 52-year-old male presented to our hospital with history of recurrent transient ischemic attacks and with blurred vision and left-sided weakness that was confirmed by the physical examination. So a left internal carotid artery stenosis was suspected at that moment, and a decision was made to go for the therapeutic cerebral catheter angiography. And the initial findings of that was, we found that there is less than 30% of left common carotid artery stenosis, as you can see here in these pictures. Let me show you. So here we can see the left internal carotid artery, and in this one also you can see the stenosis. Actually, it's not that much, but we have less than 30% stenosis. However, we have faced some technical difficulties during the angiography that lead us to
maybe that slide was the vert, Jonas, maybe it's the vertebral image. Yeah. These are maybe mixed. These are the vertebral image. And go on. Just a correction.
Sorry. So we have faced some technical difficulties during the procedure that led us to discontinue the procedure. And by that, I mean that we couldn't visualize the anterior circulation of the brain. And after multiple attempts, we could successfully visualize the carotids, but by the injection of the dye material into the ascending aorta itself, which is a special technique in that moment. So as you can see here, this is the material, dye material, and you can see here that there is a thin shadow of the carotids. That's why we couldn't visualize them in the first time. This is the right carotid, and this is the left carotid.
Yeah, that's the carotid. That's perfect.
So, as for the management, medical treatment was advised, and CTA of the head, neck, chest, and abdomen was recommended. Now we will move on to the CTA findings of the head and neck. So diffuse stenosis of the left common carotid and internal carotid was confirmed by the imaging, as you can see, and the right common carotid had mild narrowing in it. And also we noticed watershed infarction of the brain in the imaging. As for the CTA findings of the chest and abdomen, we could diagnose the type 2 right-sided aortic arch with aberrant left subclavian, as you can see here in the imaging. And also we found 5 other different anomalies, and I will discuss them in the next slide. So the list of the associated anomalies is as follows. First, we have found Comaris diverticulum. And what I mean by that is an enlargement of the origin of the left subclavian artery, and it is usually associated with this case, the right-sided aortic arch with aberrant left subclavian artery. The second anomaly was aneurysmal ascending aorta. As for the third one, we have found that we have a bilateral common carotid artery and left internal carotid artery stenosis. And for the fourth one, we had a pancake kidney. And in this case, the 2 kidneys are fused together with no septa between them, and the parenchyma of them is fused. And the final one is a persistent left-sided superior vena cava. So for our knowledge, this is the first case in the literature with such associations with the right-sided aortic arch. And in conclusion, we presented an extremely rare case of right-sided aortic arch with aberrant left subclavian that was associated with a group of extra-rare anomalies. It is tremendously important to improve investigation methods of these vascular anomalies, which may aid in better management and follow-up of these anomalies. Also, choosing an appropriate diagnostic catheter and how to advance this catheter to the common carotid artery are essential points to overcoming technical difficulties in such cases. And before I end my presentation, I would like to thank my colleague, Fatima Day, which helped me through this case report. And also thanks to Dr. Host for letting me in this case report and giving me the opportunity. And thank you for your time. Those were my 2 presentations.
Thank you. Thank you, Eunice.
You're welcome, Dr. Host.
I would like, can you show just the slide with the, because you described the anomalies. No, the CTA slide. Yeah. The CTA, chest, abdomen, and the brain. Yeah, this one. Yeah, because you described the anomalies in the next slide, then we need to see a little bit of just to give the student an idea about what they are seeing. So if you can describe whatever you find clear here.
Yes, so starting with the type 2 right-sided aortic arch, which is this one. And as you can see here, the Comer's diverticulum, which is the dilatation of the origin of the left subclavian artery. And then we have the, okay, so we have here the pancake kidney, one of the anomalies also, and aneurysmal ascending aorta, as you can see here. And what do we have also? Let me see.
Bilateral stenosis of carotid, you said?
Yes.
Yeah.
We spotted this one here and this one.
And the idea is the main idea is that in the arch, if you like for
Yes,
people.
exactly.
Yeah. For
So
people.
the right side aortic arch.
Yeah. Like I want to add just for people who don't know about this, if they see what you are showing in the superior figure, that there is 4 branches arising from the aortic arch. That's simply the start of question. Why there is 4 branches? We know that usually they are 3. Then why there is 4? So this is the start. Then everybody start to search for the association and description. And I think you need more angles of figures to see all these exactly, the diverticulum, the aneurysmal dilatation. But yeah, all the things start from the abnormal branching of the arch, and this propose a difficulty in the diagnostic catheter angiography. That's how we start this. And yeah, as you explain it, this is a suggestion to highlight this association for those who are treating such diseases, whether from neurosurgical perspective or even from like the general medicine, because this is a multi-systemic association. I'm really thankful for your presentation. I would listen to few comments if your colleagues have, and you can stop the sharing.
Yes, of course.
Yeah, Jafar.
Hello, I'm Jafar, Najaf, Iraq. Thank you, Yunus, for this beautiful presentation. It's a very interesting case indeed. My question is that, do you have in your mind any possible mechanism of pathology? I know this is most likely congenital. So do you have in your mind any etiology most likely playing a big role in this patient, or patients like himself? Yeah.
Thank you, Jafar. So as we were doing some research, we found that, as you said, all of those anomalies are usually associated with congenital cases. So usually this is the case, as we found. We tried to find some other etiologies, but couldn't actually.
And did the patient have any other problems? Like, were his kidneys okay? His other organs?
Well, this is the case. So the patient was actually asymptomatic. This is our case. So the right-sided aortic arch is usually associated with dysphagia or dysphagia or those other symptoms of this case. However, our patient presented with neurologic symptoms rather than those symptoms, like tracheoesophageal symptoms. So this is totally asymptomatic for us.
Okay. Just one more question. He had TIA, I think. So do you think it was due to his pathology, his avascular pathology, or due to simple atherosclerosis like any other patient?
Well, actually, my knowledge in this field is just not so much to give this decision, but I think Dr. Hose will answer this question better than me.
Yeah. Okay. Thank you for the question, Jafar. What do you mean by other atherosclerosis? Like, it's definitely atherosclerosis, but when in case of TIA, you are searching for the origin. So the origin either from carotid or from the vertebral. there is stenosis in them, or maybe the source from the heart. So during the search, we localize a carotid stenosis ipsilateral to the symptomatic area of TIA. So that's the process. Now, is that clear, or where is your question on that process?
Yes, that's clear. What I was trying to say is that was there like a problem in his vascular wall? Because as we saw, like he had many associated problems. Or was the stenosis because of atherosclerosis, or was it due to congenital problem?
Yeah, the answer is like both. First, it's a rare case, as Yunus answered. It's he's 50 in age, so in 50 years without a presentation related to his symptom. That's number one. Number two, we usually call this a retrograde diagnosis. Like, as a neurosurgery, we are the last people to manage these cases, so it's very rare to find the diagnosis, then get back to to understand more about the systemic disease. So this is a retrograde diagnosis, and the cause is that the patient asymptomatic. He didn't complain of any other symptom related to his kidneys, heart, arch, as you want to say, tracheal compression, esophageal compression, or whatever. And so if I want to put your question in a more informative statement, I will say the patient has already congenital stenosis, and this will be an added factor and increase the risk of TIA. So we treat the patient in this background, that this congenital malformation is an added factor to a general state of atherosclerosis. So a combination of them can cause TIA, and it's very localized. So the artery with the severe stenosis, or the more stenosis, is the artery that supply the same area that the patient complain of ischemic symptoms of it. Okay.
That's clear, doctor.
Thank you. Thank you, Jafar. And thank you, Yunus, for this nice presentation. I really I'm happy with that. I would ask for more comments, but today we have a limited time a little bit, so I will go to the next topic. And yeah, thank you, and I will be waiting for your third and fourth presentations.
Thank you, Dr. House.
Thanks.
Sure.
Thank you. I will share now another case. Let me get it ready to no more quizzes. So, who's the volunteer? Yeah, Nicola, Naba, Omar. So the three of you, Nicola, Naba, Omar. Omar Muhammad. Okay, so our case today is 19 years female, has a vascular lesion. The presentation is somewhat vague. The most important for you is she has a left side weakness. Nicola, can you describe this CT scan for me?
Yes, there is an hypodense area, which I think it's because of it explains why there's the right-sided weakness of the patient, because
left-sided, yeah.
Yes, it's on the left side, and it's near the. It's between. I think it goes in the. It's in the temporal area.
Yeah.
And
So just to make this clear, this is a right side and causes left side weakness. So this is a hypodense area as you described in the right side and causing left side weakness. If you describe the location, this is very challenging. You say temporal, I will accept that, but I will need more suggestion other than temporal. Because if you do you see my pointer?
yes.
Yeah. So if let's go to the normal side and discuss. So if this is the Sylvian fissure, this area is temporal, this area is a frontal, this is the basal ganglia. Sometimes you call it deep parietal. And if you see the lesion, it will be more in between those three. Like it's in the temporal, but the superficial part of temporal is preserved. Frontal also, most of it is preserved. The basal ganglia, there is involvement, but it's not a real basal ganglia lesion. So it's usually between them. That's why it's difficult, even for us. And by the way, do you have a suggestion what's this pathology maybe? Because it's hypodense. This is the question for Nicola and Omar. If you have any idea, if you have, let's give me a differential diagnosis, at least give me some diseases that you are thinking of. What's this? This is a tumor, hematoma, ischemia.
I mean, I don't think it's tumor.
Why? Because it would be nice if we know why.
I mean, it's hypodense and also the limit of it I mean, it does not really seem like a tumor.
Yeah, why? Because hypodense only seems like a tumor. Hypodense, maybe ischemia, maybe tumor. Let me say to you that most of the tumor are hypodense in CT scan.
I mean, it seems like there's no edema. Edema.
That's perfect. That's very, very important. The sulci are already open, so it's not an angry lesion. It's not the lesion that causing a pressure around. This is just to have an idea. So a tumor, maybe we put in the differential, but it's not in the first differentials. Other than hematoma or ischemia, do you have any suggestion?
I think it's ischemia.
Omar, you say ischemia. Which type of ischemia is this? Because we already studied ischemia like 2 sessions ago. The area that's supplied by this related to which artery, which supply? Because ischemia, we say 2 type. Either it's related to one of the main artery, either anterior here, middle here, posterior here, or some basal ganglia perforator, or maybe a lacunar that's very small. So this is not a fit for the description of this lesion. I would answer like ischemia, I can put it in the differential. And this is a typical with the history. I need a little bit about the history. The history is like 2 weeks ago or 3 weeks ago, the patient has sudden left side weakness. Sudden means there is a vascular accident in the brain because it's 19, as you remember from slide 1. So 19 years, female in this case, and all of a sudden have left side weakness, and you do CT scan, you will see hemorrhage or ischemia. This is a hemorrhage. And why we see it black hypodense? Because it's already few weeks from the incident. So with the time, we call this a resolved hematoma. Or we can say, to go with Omar option, this is ischemic area resulted of an old hematoma. Okay, so and this is not a tumor, as Nicola said. So officially, this is the description for me. This is a resolved hematoma. And what's the best to describe the location? It's maybe deep temporal, as Nicola said, or maybe I would suggest a perisylvian, because I can see the sylvian fissure here is just open. That's the initial, and it's resolved. Do we need to treat this patient, by the way? Naba, do you have an idea?
Sorry, doctor, the internet's not it's not good with me, so I didn't hear you.
Basically, this is a resolved hematoma. I told you this is a resolved hematoma. So do we need to treat this now?
I think, yeah.
I think no. like if it's resolving, we don't need to.
I thought it's ischemia, by the way.
Yeah. I told you exactly why it's not ischemia here. It's not related to any territory, and the previous CT scan showing already hematoma, so we know this is a resolved hematoma. If a hematoma after a few weeks, why I need to go to this? This is an old clot. However, and it's not causing compression with this large size. However, for this age, I would go with your option, Naba. It's not to go to treatment, but at least to do more investigation. Okay. So because question
he was 19 years old, right?
Yeah, 19, all of a sudden, no trauma and this lesion. So now I should tell the family, I don't need to treat her now with the surgery, but I need to do another investigations just to see what's the cause of this. And when this is the initial CT scan, by the way, and this is the first CT scan for her presentation. And when we go to imaging, like vascular imaging, CTA, we found this. Do you see the hematoma now, Naba, the resolved hematoma?
Yeah.
Okay, so there is a vascular tuft. A tuft mean like a collection of vessels, and this is a small AVM. Okay, and where it's located, it's the same location, frontal, temporal, sylvian. It's mainly a sylvian AVM. So, because this is the middle cerebral artery, so it's around it more frontal side. Are you okay, Nicola, Naba, Amar, till now?
I have a question.
Yeah.
Yeah. You mentioned that you might do something since she's already only 19 years old. So what are you afraid that might happen, so that you want to search for the cause of the bleeding?
Okay, that's a good question. Like if you have a patient, Amar, with this hematoma, okay, so you need to evacuate the hematoma. That's it. However, are you okay with me? Do you listen to this? Yeah. However, if you have a patient like this with the hematoma already resolved, you don't need to treat this patient urgently. However, having a cerebral hemorrhage in patient at like very young, it's very alarming of underlying pathology, maybe congenital vascular lesion. That's how it works. Or maybe some metabolic diseases. So at least you need to do further investigation. The idea is to prevent recurrent hemorrhage or prevent recurrence of such diseases in the future. Okay?
Yeah, okay.
So that's why we go to the next step and, I'm sorry. Yeah, and we see that there is an AVM underlying it. And I can tell you that from the first look, I would suggest cavernoma or AVM with the patient age, because the age is 20 to 30 is the age of AVM and cavernoma, 30, 40, 50 is the age of aneurysm. This is from vascular perspective. And yeah, you can see this lesion is, I think, clear here. And do you see this cavity? Yeah, this is the cavity and this is the AVM. So it's very obvious that this is the source of blood. And you can see how much the cavity is large. So we identify this. This is the nidus of aneurysm. Do you see this? This is the nidus. It's originated from the cerebral artery. It's located here. Okay. And we go. This is the AVM now. I'm showing you the advantage of more imaging, the CTA imaging. At that time, we don't have catheter angio pre-op. So the maximum we have this one, the CTA, so we can see from different angle, and yeah, doing more MRIs to study more. This is the circulation. This is MRA, by the way. And do you see this? This is the AVM. So this is the carotid, this is middle cerebral, and this is the AVM. It's originating from middle cerebral clearly. And this is the MRV, and let's go to the operative video. I'll try to make it rapid video. It's not the usual video that we spend much time of it. Yeah, this is the operative video of the patient. We are very happy to have it. We have many students, Rokhaya, Mustafa, Aktham, at that surgery, and this is the case. We go through, sorry, let's see the first few minutes. So this is like the opening of sylvian fissure, how we open the arachnoid between the frontal and parietal. And you remember this is the right side. I usually let the superficial part for resident to help and to understand more. This is the middle cerebral artery down in the sylvian fissure. And we go through the lesion. What is the lesion? I just want you to see part of the lesion. Sorry. Yeah, so we identify a vessel here. We put a clip. We go more. And yeah, you can see this is the abnormality here. It's not very clear because it's down in the screen. However, yeah, this is the lesion, and we remove this. We put, there is a specific type of surgery for AVM. I will describe it in details after this online session, maybe later, because I have many videos of AVM, but I want to go to a specific thing. In this case, like after resection, getting through all feeders, and then go down to the venous drainage as the last part to be removed. And now we make sure that everything is okay, and we are removing our clips, and we think that, yeah, it's done. Surgery is good. Patient post-op is very good. And this is the celebrating team. However, do you see the screen now?
Yes.
Yeah. However, I'm still with Nicola Nabe Amar. This is the post-op CT scan. It's good. There's nothing new, which is by itself is good. And here you can see there is something, which is the clip that we put it on the venous side. Everything is okay. And this is the opening we used for this patient. And this is the clips that we put on the vessels. However, 1 week after the surgery, before discharging the patient, I intend to do a CTA checking before discharge. So this is the CTA. Wow. This is the lesion. So it's partially removed. We don't remove all the lesion. And where was this part? We remove all the thing. The answer is simply the lesion was frontal and temporal, and we remove only the frontal part. This is very challenging. And what to do in this case? It was very challenging decision to go from CTA direct to the patient. She was very happy that she did the surgery well, and she has no weakness, has no problem after the surgery. Even the weakness improved after the surgery. And however, I'm here at the door of the patient room, and I'm telling them that the surgery was okay. However, it's not successful. It's not successful in removing the full lesion. So what we need to do, we need to do another surgery. I decide to, based on the patient's psychological state at that time, to delay the second surgery until 1 month. And then we do another CTA to see if there is the same thing as a remnant. And then we go to do another surgery. And I think you see how clear that this is the part we do it. Do you see this? And this is the part remaining. And this is the craniotomy. This is not funny, because when you are the surgeon, this is not funny. This is a serious thing. And yeah, so this is the redo surgery for the patient, and it's not uneasy. You can see the difference from the first surgery. There is a lot of adhesions from the first operation. The anatomy is not clear as the first operation. And by the way, you will be more aggressive now. You want to make sure 100% you are removing everything. So I intend to open even the cavity. I want to see the full cavity of the hematoma also to evacuate. And yeah, we find also in the Sylvian, it's just hidden in the first surgery. And now you can see the cavity of the hematoma. Do you see the cavity? It's very large cavity. It's just a hidden angle. Yeah, I want you to see more of the surgery later. Sorry, yeah. So now we remove everything. We make sure that everything is clear. However, you should remember that this is a Sylvian near mid-cerebral, this means any wrong vessel that can be clipped or cauterized may cause the patient weakness for life and may cause ischemia. That was the challenge. And yeah, we are just washing the brain at the last moment, and we are still make sure that everything is clear, everything is doing the perfect hemostasis possible. Definitely this is summarized. This is not all the things, but just to give you an idea about now the lesion is out and the patient is clear of her AVM. The good thing is that the patient continue in those vascular lesion. When you remove it, you will have a very good outcome if the patient is good after surgery. And by the way, we call this surgery between us as a team, like we call it something called hijama, which is something in Arabic related to cupping therapy. If you understand the cupping therapy, just to let the blood from the body, because the patient is improving after the first surgery. So what is the source of this improvement? Yeah, so we call it's like a non-successful, a fake surgery. Unfortunately, it's we try our best, however, it's not successful. And now we are happy with the result, with all the AVM removed. And the patient just, I think the last April, this is the patient graduating from college, and her father is just happy, and he said that she graduated today and with a very good degree, and yeah, healthy, wealthy. That's it. Comments?
I have a question.
Sorry?
I have a question for you, doctor. Why didn't you completely remove the damage in the first operation?
The damage, there is no damage at all. Like damage mean injury. You are not trying to injure the patient.
No,
if
I meant
you like if you are asking about why you didn't remove the full lesion from the first surgery, the answer is that's it. It's not there in the first surgery. We don't recognize this in first surgery. In the first surgery, we find the lesion, we remove it. We don't know that there is a hidden part, another part hidden in the brain. So it's unintentional. It's an error. And yeah, you must stand for your error inside the surgery. Why you don't remove the full lesion? Obviously, because we remove what we see, and what we see at what we saw at that surgery is that part, the initial part, and we remove it. Unfortunately, it was not the full AVM. That's a big lesson, even for us, for every one of us, to think again and again before closing the lesion, the craniotomy, or before leaving a surgery, just to double check, triple check that everything is removed. You get the idea?
Yeah, I get it. And
okay.
Thank you. That was a great idea for me to give us like videos.
You're welcome. Yeah, Omar, do you have a question?
Like aside from this incredible surgery, I have a question regarding the emotions. How hard is it to tell the patient and the patient's family that we have to redo the surgery again?
Yeah, it's very difficult. The patient don't accept to look at me at least at the till the end of second surgery. Like, okay. Initially, she's very happy with this, with the surgeon that's saving her life. Then all of a sudden, it's changed. For the patient, it was very, very difficult. For the family, it was very difficult. It's not written in books to delay the surgery for 1 month, but for me, I cannot do the surgery next week. They are not in the mentality now, or they cannot afford psychologically, as you said, to do the surgery, another surgery tomorrow. It's very difficult for them. So I give them 1 month to think, taking the risk of second rupture of the, maybe there will be a hemorrhage within that month. It was very, very difficult month for us. And yeah, at least nothing bad happened. Then they come, we do another CTA just to confirm the AVM is still there, and it is still there. So we go to surgery. Yeah.
Thank you.
You're welcome. One more question.
Excuse me, Samuel, we got a 10-minute warning.
Yeah.
Okay.
Do you have a comment, question? Yeah, Abrar.
Hello, Dr. House.
Hello.
Now, I'm wondering from a surgical perspective view, is it always considered a weakness point if we reoperate the patient?
Yeah, like you don't want to do this like in your career at all, but sometimes you are obligated. Sometimes there is remnant of tumor, sometimes there is recurrent of tumor, sometimes there is let's say residual AVM, residual aneurysm, sometimes more, even worse, when there is infection inside the lesion, like you reoperate because there is an abscess in your operative field. That's not an easy situation. Yeah. So keeping with the standard from the best surgery is the first surgery. Everyone know this is a rule. the first surgery is the best surgery. And I think with the few seconds that you already saw in these videos, that yeah, it's very clear. Anatomy first, the second surgery is just difficult. It's just more risky to the patient and less enjoyable for the surgeon and the team. You will be at a huge stress. You want to do the job and that's it. It's a different mindset even for the team. But yeah, for me, I was thinking that I need to show you all the examples of ups and downs within neurosurgery that I faced. And yeah, this is part of sharing experience, and that will be, if you decide later to go out of neurosurgery, and this will be very nice option if you base this on many instances that, okay, this is nice, but I don't want to talk to the family of a dead patient of a complicated case.
Yeah, that's right. Thank you, Dr. House.
You're welcome. Any comment before closing this online session? We have another case. We will go through it. I don't know if it's today or not. I will give you the answer in the group in 5 minutes. Do you have a question, Taiba?
There's a question in the chat from Sajjad. He says, do you think that the month that you gave to the patient after the first surgery made the adhesions and anatomy more difficult?
Maybe, yeah, you are correct. You are definitely correct. If I'm operating on the next day, the second surgery, it will be easier. Everything is still not healed. If after 1 week or 1 month, think there will be adhesions. But if you remember, I said that the CTA post-op, we did it like 1 week after surgery. It's not post-op directly. And yeah, we are fortunate enough to have this standard. It's not required. If you do the surgery, post-op CTA, good, you can discharge the patient and he can come for follow-up few months later for the further imaging. But for our standard, this is just the thing that we decide for our patient. It's not based on some guideline that better to do CTA before discharge. So we are we feel safe when the patient at home. And yeah, this is one of the advantages. And this case, and I think you can understand, this case give us more confidence to do a follow-up before discharge. Double check, triple check. Okay. That's that. I didn't see who's the one that give the question, and then remember this is a text. Yes, Sarah. Let's end with Sarah comment or question.
Hi, Ami. Why I have a question. Why did you not notice the lesion during the operative? Is it not present at the beginning or what?
No, it's like this is the same like Naba question, and we don't have answer for that. That's why I put it in a paper. You know how I deal with things or with complication. I put it on paper. What are the causes of remnant AVM? Because this is not recurrence, this is remnant. There is a remaining part. How we can prevent this? Definitely, I put it in a paper. It's not published yet, but yeah, I'm searching for this. Definitely, the first cause is me as a surgeon. I don't know that there is another part that I should remove. Okay. And why I don't know? Maybe further imaging required, maybe double checking required, maybe intraoperative imaging. And that's what we suggest in the paper, that intraoperative imaging is very important, like ICG or intraoperative catheter angiography. You can do in some facilities around the world. It's not available at that time in Iraq, but this is one of the advantages of these. Like intraoperatively, you can check everything is okay before you close the craniotomy, just not to make this happen again.
Yes. Thank
Okay.
you. Yes.
Thank you. So thank you, everybody. We have another presentation. We have another, I think, 2 cases, but I feel that these cases are more long videos and deserve more time. I would suggest to see you tomorrow. I'm sorry for today. I'm too busy today. Tomorrow, same time on Neurosurgical TV with the same link. And yeah, I think tomorrow we'll have 3 hours meeting. Thank you. Thank you, John.
Okay. Okay, that's tomorrow, right, Simmer?
Yeah, tomorrow.
Okay, very good. We'll see everyone. That's how you use Zoom, interact. That's great.
Yeah,
See you tomorrow.
See you tomorrow. Bye-bye.
Yeah, I have to go to Bolivia Grand Rounds now.
Oh, all the best.